Miriam. I'm an OBGYN resident at the University of Rochester. And I'm going to be talking today a little bit about contraceptive use for women who use drugs. I'd like to talk a little bit further about the contraceptive practices among women who use drugs. Society has certain expectations of what is normal and what isn't normal, and people who are considered to be outside of the normal are often stigmatized, seen as deviant, and often marginalized. When we stigmatize people, we label them and we stereotype them. We reject and we exclude them, and we internalize community attitudes in the form of shame. All of this can lead to feelings of insecurity, isolation, and powerlessness. People who use drugs are very stigmatized, and especially women, and mothers even more so. I hope today that we can talk about some of the myths by taking a deeper dive into the literature so that we can provide sensitive and informed care to all these women. Of note, I'm going to be using the term women because that's what most of the literature uses. However, when I say women, I'm referring to a group of people who can experience pregnancy at a larger scale. So, kind of our objectives for the day. I want to discuss contraceptive prevalence and uptake of specific methods among women who use drugs. I want to identify their common and unique barriers to contraceptive care and to use. I want to explore the potential models for meeting the contraceptive needs of these women. And so we'll start by reviewing the definitions and some relevant background information, and then move into the existing data on contraceptive use and interventions. So before we dive in, I kind of want to show a clip. It's about 3 minutes long. This is an interview with Barbara Harris, who is a founder of this organization called Project Prevention. This is one of the first things that comes up when you Google any topic like this, and so I figured this is a good place for us to start. Give me a moment because I'm not that great at Zoom yet.
Since the 1970s, at least 45 states have prosecuted women for using drugs while pregnant. Alabama has one of the country's strictest laws on the subject. It's been used to prosecute women even before they've given birth. And one woman in Alabama is on a crusade to keep drug users from getting pregnant in the first place.
Everybody knows a drug addict, unfortunately. So if you know anybody who's using drugs that could get pregnant, we'll pay them to use birth control. That's what we do.
Barbara Harris thinks drug addicts shouldn't have children, and she's using cash incentives to make sure they don't.
Nothing positive comes to a drug addict who gives birth to 8 children that are taken away from her. This is a win-win for everybody.
Her non-profit, Project Prevention, pays addicts and alcoholics $300 if they get sterilized or put on long-term birth control.
Swing it wide.
It says no left turn here.
You're turning right.
I'm going this way. Oh, I thought she wanted me to go that way.
Over the last 20 years, she's traveled the country in her branded RV and paid 7,000 people to give up their fertility. Most of them are women. She launched Project Prevention after she adopted 4 babies in 4 years, each born to the same drug-addicted mother.
You've been doing this work for nearly 20 years now. How have things changed?
When I first started, the drug of choice was crack. Now it's switched, and now it's meth and heroin and a lot of prescription drugs. But nothing else has changed. Drugs are still just as bad. Women are still having numerous children. Foster care is still overloaded. Hundreds of thousands of kids are still in need of homes.
The birth control she offers isn't condoms and pills. It's IUDs, implants, and sterilization. Those who choose sterilization get a lump sum after the procedure. Those who go for less permanent options are paid in smaller installments. Thousands of women have taken her money in exchange for permanent sterilization, entirely legally. Project Prevention itself doesn't sterilize addicts, just pays them. Harris leaves the procedures to doctors. She gets anything up to $500,000 in private donations every year.
I think if there's anything that everybody can agree on, the left, the right, and everybody in the middle, it says it's not okay to abuse children.
You think having a child when you're drinking and taking drugs is child abuse?
Yes. Well, they say don't even drink caffeine when you're pregnant, so I don't know how meth could be good for a baby.
Okay, so that's a little bit. I bring this up because I think it demonstrates several of the common and mostly harmful stereotypes that about people who use drugs, and I think it's going to talk a lot about some of the topics I want to talk about today. So, starting with some background. Frustratingly, there really is no universal definition of terms when referring to drug use. And they're often used interchangeably without clarification, or they're conflated with other identifiers like poor socioeconomic status, and that's even occurs in medicine as well. The literature frequently doesn't specify what the term drug use means in terms of specific substances, frequencies or amounts, and so on. But according to the NIDA, which is the National Institute of Drug Abuse, the following terms are defined as this. Drug use is the most general term and refers to any scope of use. Drug misuse is improper or unhealthy use, usually with reference to using prescription drugs other than how they're prescribed. It's roughly equivalent to drug abuse, but we often avoid this because it can be shaming and stigmatizing. Addiction refers to substance use disorders at the severe end of the spectrum, as defined by the DSM, which are diagnosed according to several criteria like cravings, withdrawal, and continued use despite negative consequences and impaired function. And so a little topic about person-first language. Instead of saying drug users, addicts, women with substance abuse, or other common slang words, I'm going to be using the first-person language by saying women who use drugs. I do this to acknowledge that drug use is not the only important thing or really the defining thing about these women, and I will try to specify use where I can about the specific types of drugs that they do use. So now to start in. So the population I am referring to when I say women who use drugs, which population is that? Who are these people? Most of the data that focuses on women who use drugs or have substance use disorders focus on women who use opiates. And I'm going to review those numbers here. Recent data from the 2017 survey on drug use and health estimates that there are over just 2 million people in the US that have an opiate use disorder. So 2 million people misuse prescription opiates for the first time that year, and about 1 million people have used heroin in that year. 1/3 of all of these people are female, 90% of them who are reproductive age. About 21,000 pregnant women will have used opiates in the last month, and over the last 20 years or so, there's been a 4-fold increase in the number of women presenting to labor and delivery who have an opiate use disorder. As I'm sure you all know, the problem with the opiate epidemic is walking through our doors every single day. It's affecting our patients, and maybe most importantly, it's affecting women that don't come through our doors, women who aren't engaged in care, maybe at all. This here is just another graph that demonstrates that drug use affects pregnant women and non-pregnant women alike, especially those younger than the age of 25. So, as we know, the rate of unintended pregnancy in the US is around 50%, and worldwide it's about 40%. We also know that unintended pregnancy disproportionately affects minority women and women of low socioeconomic status, as the graph on the right demonstrates. However, among women who use drugs, the rate of unintended pregnancy is even higher and almost unbelievably so. It's about 70 to 80%. A study from 2011 took it a step further and delineated the subtypes of unintended pregnancy among women who use drugs by asking them, when did you intend to become pregnant? Within the 86% of unintended pregnancies, only 27 were considered actually unwanted, which is actually a really interesting number. This means that the women who said never to that question. The rest were categorized as either mistimed, getting pregnant earlier than planned, or ambivalent. I think this kind of highlights what I hope to convey through this talk, which is that this issue is more nuanced than we really consider it to be. Any woman who becomes pregnant unintentionally has to figure out how to handle this significant life-changing situation now on their hands, beginning with the decision of whether or not they want to continue the pregnancy. Choosing termination comes with its own challenges and barriers. Pregnancy comes with its own inherent risks and complications, morbidity and mortality. Women with unintended pregnancy often enter prenatal care much later than someone who has planned to get pregnant, if for no other reason than recognizing it as early. For those who do deliver, there is the cost of caring for a new human, and often a delay in an employment or education status if one doesn't have the desired resources they needed to access childcare, as many do in the United States. Women who use drugs face all of these challenges, plus others. The utilization of prenatal care is significantly less for a number of reasons. Yet we know that good early prenatal care can mitigate many of the negative perinatal outcomes associated with drug use during pregnancy. For example, low birth weight and prematurity. One huge barrier to prenatal care is the fear of consequences of revealing one's drug use to a provider. This is because of stigma and because of the real laws and politics that punish women with these circumstances rather than help them. The Child Abuse Prevention and Treatment Act, CAPTA, which was first enacted in 1974, is a piece of federal legislation aimed at preventing child abuse and neglect. It was recently amended to require that states to notify child protective services and to implement plans of safe care for babies born exposed to opiates or other substances. As of just a few years ago, 18 states declared substance use in pregnancy as a criminal child abuse punishable by law, which can result in termination of parental rights and involuntary detention or commitment to mental health facilities, treatment programs, or correctional facilities. Even though we know that incarceration or the threat thereof is ineffective at reducing the incidence of substance use among people, especially mothers. We know that legally mandated drug testing and reporting puts at risk the trust and the therapeutic relationship between the provider and the patient. And we know that it leads to avoidance or disengagement from prenatal care, which can greatly reduce the negative effects of substance use in pregnancy. These policies are contrary to the health and well-being of our patients. So avoiding this whole situation by preventing unintended pregnancy in the first place is hugely important. Just want to throw in there ACOG, which is the OBGYN college. Our official opinion is that providers should focus on providing care and not reporting to CPS. I'm happy to talk about the CPS issues at length, but that would probably be another talk. So, with all that in mind, let's talk about family planning. Publicly funded family planning services help women avoid pregnancies that they don't want and plan pregnancies that they do. It's that simple. According to the Guttmacher Institute, in 2014, these services helped women avoid nearly 2 million unintended pregnancies, which would likely have resulted in 900,000 unplanned births and nearly 700,000 abortions. The graph shows what anyone here could guess, which is that unintended pregnancy occurs most among women with non-use or inconsistent use of contraception. So now I'm going to move into a growing body of literature that examines contraceptive uptake in women who use drugs, and specifically what methods they're using and why. The problem of opiate use in the US dates all the way back to the 70s, if not even earlier, but most people who used opiates at that time were men. Even still, a few researchers around that time were interested in assessing contraceptive use among women who use drugs. So this idea is not new at all. It just gained a lot more attention over the last 10 to 20 years or so, given that opiate use has overall increased, and then that demographics today reach far more women, most of whom are reproductive age, as I mentioned at the beginning of this talk. This is a clip of the earliest dated study we could find examining contraceptive use. It was published in 1986. The authors performed a chart review of 115 reproductive age women on a methadone maintenance at a California clinic, which assessed contraceptive status as part of the clinic's admission process. They found that only 26% reported using any type of contraceptive method, compared to 49% of women matched for economic status from a national study. And while there's limited data from those earlier periods, there have been numerous studies published since that time, most of which have come out since the year 2000. In 2015, a review paper was published from some researchers in Maryland and Vermont. They examined 24 studies that included over 5,000 women with drug and alcohol use, the majority of which reported opiate use. Contraceptive prevalence was widely varied, with the median falling at about 55% as compared to just over 80% in the non-drug using population. Regarding method choice, less effective methods, primarily condoms, were the most prevalent. About 60% of people said that. Whereas LARC, which is the long-acting reversible contraceptive, was reported at only about 8%. LARC is things like IUDs or Nexplanons. For comparison, here's some data from the Guttmacher Institute on contraceptive prevalence in the general population. 60 to 80% of reproductive age women currently use a contraceptive method, and only about 10% of women that are at risk of unintended pregnancy are not currently using a method. The highest in that group is about women aged 15 to 19, 18% who didn't use any contraceptive method. And of those currently using contraception, 72 used a non-permanent method, 22 have tubal ligations, and 7 use male sterilization. Only about 14% have used condoms as their most effective method versus greater than 60% for about women who use drugs. Just under 15% of women using a contraception relied on a long-acting reversible contraceptive method, or LARC. 12% used the IUD and 3% used the implant or the Nexplanon, compared to about half of that among women who use drugs. So from this, we can see that women who use drugs who don't desire to be pregnant rely on less commonly used methods and less effective methods, particularly like condoms. So let's try and understand why this is the case. So this is just a picture from a 2016 NPR article discussing the massive uptake in social media talks about IUDs when Trump got elected. I thought it was relevant for right now. So it's a strong start to know the numbers for prevalence and methods, kind of as we just talked about, but that's just not enough. This information needs to be contextualized as far as what women want or what they intend to be using, how they perceive various contraceptive methods, and what factors influence their contraceptive decisions, including their perceptions about pregnancy, and thus their desire to prevent it. I'm going to review some studies here. A study just recently published this year explored women's perceptions of pregnancy by conducting in-depth interviews with 22 women in medicated assisted treatment, or MAT therapy. Several themes emerged from these interviews. First, a paradox of stability, such that women commonly acknowledge unstable living, employment, and healthy circumstances as reasons they wanted to avoid pregnancy. But they simultaneously cited being in stable monogamous relationships as a source of coping with or even desiring pregnancy. Second, women reported mixed feelings about their fertility. On the one hand, they had fears about how the drug use might limit their current or future fertility, and thus were ambivalent about preventing it for the fear of it never happening. On the other hand, women desired different circumstances in which they'd want to have a baby and expressed fears about the potential impact of the drug use on the fetus. Third, many women expressed fatalistic attitudes about pregnancy, saying things like, I'm just kind of testing fate, or whatever happens, happens. And fourth, and kind of most importantly, there's a low pregnancy risk perception. We know that it's not uncommon for women who use drugs, especially opiates, to become amenorrheic, and this causes confusion about their fertility status. This misconception has been reported in other studies as well, and is also combined with frequently cited low sex drive or infrequent sexual activity. Finally, several women expressed how their drug use interferes with their priorities and ability to make proactive decisions about pregnancy prevention. A handful of studies have assessed women's perception and knowledge about contraception, and I'll review a couple of those here, but know that we talk a lot about this. In this study, they assessed interest in, concern about, and knowledge of LARC, or the long-acting reversible contraception, among women in MAT therapy for opiate use disorder who are at risk for unintended pregnancy. They found that 90% had heard of IUDs or implants, and 34% had used LARC in the past. But only about 40% reported being likely to ever use an IUD or an implant, an Nexplanon in the future. This is pretty comparable to the 25% of young women who said that they would be interested in using an IUD. When asked why, potential reasons given as answer choices were doctor's advice not to, friends or relatives' bad experiences, worries about side effects, insertional process, or concern for infection. Most women cited concerns about side effects as to why they had concerns about it. Most likely, they were concerned about getting an infection. They also assessed self-perceived versus actual knowledge about the method. And while most women thought they knew less about IUDs, their actual knowledge was similar across the methods, except for the implant, which most people didn't know that much about. When asked about the relative effectiveness, only 60% knew that an IUD was more effective than a birth control pill, and about only 51% knew that for the next one then. This was a study of 42 pregnant or recently pregnant women in a drug treatment program. Results showed that most women relied on condoms, about 70%, or pills, about 60% for their contraception. And only a total of 17% had used LARC in the past, and most of those had been the IUDs. Yet a total of 37% said they would prefer a LARC or a BTL if it was freely provided for them. When asked about the side effects, almost 50% reported not knowing how they'd be bothered by the IUD. So this just goes through a couple of other studies talking about the prenatal intent and postpartum receipt of different forms of birth control. One study assessed postpartum contraceptive use among women who are being treated for substance use during pregnancy. They found that among 161 women, the rates of postpartum contraceptive use were actually fairly high, about 70% at 3 months and 65% at 24 months. Mostly people are using Depo or condoms, though. So to summarize all of that, the data suggests that women who use drugs are less likely to use contraception and are more likely to rely on less effective methods when they do. Now I'll talk about why and what might be getting in the way of women accessing contraceptives that they want. There are multiple levels of influence regarding access to and utilization of care, and the results of some of the studies we just reviewed have already highlighted some of these barriers. At the patient level, beliefs, like I mentioned before, about perceived infertility, mixed emotions about pregnancy, affect how high or low the risk of a patient believes she is at for becoming pregnant, and therefore the need to prevent it. Lack of information and misinformation, often heard from friends and family members, significantly affects patients' preferences and thus their likelihood of uptake of certain methods, especially LARC. Other factors, like the possibility of intimate partner violence, reproductive coercion, denial or embarrassment about substance use, and histories of sexual abuse or trauma also play a role. For example, for intimate partner violence, a recent review and meta-analysis found that experiences of intimate partner violence were associated with a significant reduction in the odds of women using contraception, and women with intimate partner violence are less likely to report their male partners using condoms. At the provider level, there's unconscious biases and discriminatory behaviors that have direct effects on patient interactions and women's experiences with the healthcare setting, many of which they report are negative, including forced treatment. Often providers are not trained to provide comprehensive care or care that addresses both a patient's substance use treatment needs and their reproductive health needs, leading to misunderstandings and or the need for multiple different providers. And finally, at the system level, there's the financial burden costs and the conventional referral system that requires follow-up, et cetera, et cetera, et cetera. So what are the opportunities for intervention? What is being done to address these critical gaps in care affecting the lives of many really quite vulnerable women? And how can we help? There are 3 current models for intervention. The first stems from behavioral economics and is based on incentivization of healthy behaviors. The second is focused on coordination and combination of services, specifically drug treatment services and reproductive health care services provided together at a single site. And the third is aimed at increasing provider knowledge through cross-training. For example, such that OBGYNs can simultaneously offer MAT therapy, things like Suboxone or buprenorphine, and or APPs at the methadone clinic can offer contraceptive counseling. So this brings us back to where we started. What can we learn from project prevention? I kind of hate to even give it any airtime at all by including it in this talk, but it deserves a conversation, at the least. First, because they're expanding their region of influence, for example, into some African countries and into Australia now as well. And second, because the general idea of incentivization warrants some consideration. There are so many problems with the project prevention operation, not the least of which is included its ethically objectionable activities bordering on reproductive coercion and compromised autonomy, informed consent, its perpetuation of harmful stereotypes and medical misinformation, and its use of eugenic-sounding rhetoric that a defined and identifiable group of women whose reproduction is problematic and needs to be prevented, and its frank disregard for the numerous complex contributing factors to women's drug use and their life circumstances. Yet there are several bodies of literature showing that the use of incentives to change health behaviors is not uncommon, and it's valuable to examine doing so in the context of today's discussion. So under what circumstances, if any, is it ethical to offer incentives to encourage women who use drugs to use contraception? This is obviously debatable and requires us to answer some of the following questions. What are the reproductive rights of women who use drugs? That is, who's allowed to have a family? At what point does a monetary incentive undermine the ability of these women to make free and informed decisions about contraception? And how can we best help women who use drugs access to reproductive health care and treatment services that they want or need? In response to the debate provoked by project prevention, there is a recent paper published including different types of providers' opinions and suggestions regarding the questions I just asked. Some ideas include smaller, non-cash incentives, for example, vouchers for goods or services, continual reinforcement versus immediate upfront gains, contingency models, linkage to receipt of contraceptive counseling and a cooling off period before a decision is confirmed, and the absolute exclusion of permanent contraception as an option. There's a group at University of Vermont working on this right now. They published a paper in 2016 that described their study on an incentive model to promote contraceptive use among women who use drugs, particularly opiates. They assigned 31 women to usual care incentive groups. Usual care included providing condoms, emergency contraception, referral to local providers, and the intervention group provided contraception initiation protocol, which includes free contraceptions and financial incentives for attending follow-up visits over the next 6 months. The financial incentives were vouchers starting at $15 for the first visit and increased by $2.50 for each subsequent visit. They could be used to purchase retail items from the community. They found that significantly more women in the intervention group initiated contraceptive use, 100% versus 29%, and continued contraceptive use over the follow-up period, 63% versus 13% at 1 month. Additionally, no women in the intervention group became pregnant during the study period, whereas 3 women, about 20%, in the usual care group did not become pregnant. Another thing to consider is provider cross-training. In 2013, the American Board of OBGYN released an update regarding the scope of practice for OBGYNs. Needless to say, it went through a couple renditions, but now OBGYNs are allowed to spend some of their time prescribing MAT therapy, things like buprenorphine and Suboxone. Third is co-localization of services. A study in 1995 of 203 opiate-dependent women in a drug treatment program found that 73% reported that they'd use a contraceptive clinic if it were available to them within their program. Yet a few studies from 2005 to 2015 reported that despite the need for incorporating women-centered services, especially during pregnancy, less than half, about 40% of outpatient substance use treatment facilities offered any of these services, and have failed to incorporate specific clinical pathways for pregnant women or postpartum women to get the services that they need. A group from UVM did a chart review of 98 women with 2 consecutive pregnancies that delivered at their hospital who had received MAT therapy, either through a public or community opiate treatment program, or through an OB provider with co-localization of prenatal care and MAT therapy. Of note, women made an average of 11 to 12 antepartum visits, which demonstrated that the prenatal period is a time of consistent engagement and care, and this is an opportunity for us to educate and provide ideas for postpartum contraception. Overall, they found that 84% of all pregnancies were unplanned, and over half, about 56%, had a short inter-pregnancy interval of less than 18 months, whereas the national statistics suggest that 30% of the general population has a short interval pregnancy. Half the women received no postpartum contraceptive method at all. Notably, over 42% of women desired a LARC, the long-acting reversible contraceptive, but only 9% received it. So this is something that's concerning to us. Interesting, these outcomes were not any different between the models of care. They did not co-locate postpartum care with MAT therapy. So even though they co-located the care during their pregnancy, they did not co-locate the care between in the postpartum period. And women who had planned for postpartum MAT were transitioned to other non-co-localized treatment services. This circles back to the challenges of the referral system and requiring women to maintain engagement and care across multiple providers. The Family Planning Initiative was a project out of Johns Hopkins from 2005-2009 that assessed the delivery of contraceptive services within a pediatric clinic within a drug treatment facility. A provider was available to offer prenatal counseling, postpartum appointments, and reproductive health education modules. Over the course of the project, they saw nearly 700 women, and more than 200 of these women received the desired tubal ligation or LARC method. Another example of co-localization of services is the Pregnancy Recovery Center, a buprenorphine treatment center that was run at a UPMC and staffed by OBGYNs trained in addiction medicine. The center offered truly comprehensive care with services that ranges from prenatal to postpartum care to housing to transportation services. This study came out of the project compared pregnancy-related outcomes between women who received care at the Pregnancy Recovery Center and women in regular continuity medication-assisted treatment centers. The authors found that the Pregnancy Recovery Center patients were significantly more likely to have higher buprenorphine doses at the time of delivery, more likely to attend their postpartum visits, more likely to receive LARC within the first 6 weeks of delivery, and more likely to continue breastfeeding after delivery. All things that we think are good things for patients. The last thing that I think is important to mention is that ultimately we cannot or nor should not force decisions about contraception on women, regardless of what we think is best for them. We can only offer information and guidance and increase accessibility to resources and let the women choose from there. It's their body and it's their choice, and it's our role to remove the barriers they desire for their own reproductive health. Thank you.